Good morning and welcome to the fourth Diagnostic Leadership Summit. We are now heading into the panel discussion on the evolving facets of antimicrobial resistance. We are delighted to welcome Dr. Sonal Saxena, Director, Professor and Head, Microbiology Department, Maulana Azad Medical College. Welcome, ma'am. Dr. Mathulik Savathekar, Director, Lab Services and Head of Infection Control, the Hydri Group of Hospitals. Welcome, ma'am. Dr. Aruna Pujari, Head of Department, Pathology and Microbiology, Beach Candy Hospital. Welcome, ma'am. Dr. Namita Jaggi, Chairperson, Lab and Infection Control, Chief Education and Research, Artemis Hospital, who will be the session moderator. Welcome, ma'am. And Dr. Shehzad Mirza, Associate Professor, Microbiology, Hospital Infection Control Officer, Dr. D.Y. Patil Medical College, Hospital and Research Center. Welcome, sir. I now hand over the session to Dr. Namita Jaggi to take the discussion forward. Over to you, ma'am.
Thank you. Thank you for that introduction. And welcome to the audience and to my co-panelists on this evolving facets of antimicrobial resistance in the fourth Elets Diagnostic Leadership Summit, with the overall theme of decoding the futuristic diagnostic sector. Now, we all know what a pressing and what a challenging problem is antimicrobial resistance globally. And somehow, if we discuss about our plans for the future, we feel better. Though I don't really know what much we can do about it, but there is still a lot we can do about it. So, as we attempt to look into the future today in the panel discussion, we'll be talking about 4 futuristic facets of AMR with our esteemed experts. The first one is role of surveillance in managing antimicrobial resistance. The second is applying advanced diagnostics in improving the AMR detection. The third would be the AMS programs, that means the Antimicrobial Stewardship programs, and effective infection prevention and control strategies to control the spread of the antimicrobial resistance. And the last but not the least, I think, which forms the basis of all this, is strengthening the research and innovation to address the challenge of AMR and also the One Health approach, because now we realize that the antibiotic resistance is not only limited to the hospitals. It is actually an environmental problem. You know, one of the, Dr. Philippi, I think, from the Institute of, the Pasteur Institute in France, he said that the antibiotics have now ceased to be the magic bullets, but they have changed into major environmental pollutants. Actually, they're all around us. So we must understand that how we can address this One Health approach and the use of the antibiotics in the other sectors. Also, we need to see what are the challenges in having the newer antibiotics coming into the fore. Why is there not so much of a research on the antibiotics, and what is the problem of the newer antibiotics, and why are there so few in the pipeline? Now, all these facets which I have chosen, they are loosely designed on the global action plan, which was instituted by WHO in 2015 and subsequently followed by various countries as their national action plan. And as you know, that India also has a good national action plan, which was started in 2017. And that is why we've tailored our facets around these action plans. So let's begin. So now I will start off with Dr. Sonal Saxena, who has already been introduced. And I'll just like to say that, she is a very well-known name in our microbiology and antimicrobial resistance. And not only that, she's the program director for a very wonderful, a very effective and robust program. She is the program coordinator for the Delhi State Surveillance Network, which is the WINSAR-D. So I'd like to actually start off with Sonal. And here we must understand that what we don't measure, we cannot control. And so what we measure, the extent of that measurement, we understand a lot of things about it. And so, Dr. Sonal, my first question to you would be, how does surveillance broadly and surveillance networks specifically contribute to the fight against AMR? And have you encountered any challenges in this regard? Over to you.
Thank you, Dr. Namita, for those kind words. And one of the most important thing which is mentioned in all the national action plan as well as in the glass, this thing is that all member countries have to enter their surveillance data. Because like you said, what you cannot measure, you cannot control, and then you cannot devise your strategies for further improvement. So, for doing that, there has to be a national coordinating agency. That national coordinating agency will submit data to GLASS on a yearly basis. And India enrolled in GLASS many years ago in 2013. And NCDC is the coordinating agency, and their national containment of AMR control program has actually right now about 36 members which are actively submitting data to NCDC, and NCDC further is submitting the data to GLASS. Similarly, ICMR has got a network. ICMR could enroll private institutions also in their network. So they have data from a group of private as well as government institutions. They were able to submit this data to GLASS on a regular basis. They submit it to NCDC and NCDC submits it to GLASS. Now, after that, there are more than 6,000 laboratories in this country. And if you look at this figure, this barely covers maybe 70 labs with both the networks. So there is a need that because health being a state subject, there is a need that every state should have their own surveillance networks where we can, collect this data and pass on to NCDC for any further submission to class. So, with this mind, on a technical background and on the need assessment, three states came forward. One was Delhi, second was Maharashtra, and Kerala, where they have their own state networks now. Kerala network is coordinated by the GMC Trivandrum, Mahasar or Maharashtra network by GMC Aurangabad, and the WINSA-D, that is WHO IMM Delhi chapter AMR surveillance network, is coordinated by me. And we've been running this network from 2020, from January 2020, and we are ready to publish our findings for 2020. 2021 data also is complete. Once we work ahead with 2020, we'll be able to publish. And recently, NCDC has issued a mandate that all state medical colleges will be submitting the data to uh, MAMC, which is the coordinating center for the state surveillance network. So, a kind of a system is being developed by the government so that the data starts to flow automatically after some time, because when we established the data, it was pure, didn't have any government mandate to continue. It is working till we are in the network, or maybe till we are supported by WHO for many activities, and IMM Delhi chapter is supporting us. So it was a voluntary network which we took upon. Same thing was happened with Mahasar also. Kerala network is the government network. So on those lines, we will soon be establishing a network of laboratories from the government itself. So the surveillance data will allow us to see not only the issues which are, you know, the interactive meetings that we've had. We've come to realize that there are a lot of road still needs to be covered in terms of a lot of things which we are working upon.
Myself. Very beautifully answered, Sonal. I think you have made it so clear, because I'm sure there was a confusion in everybody's mind as to what these networks are, what is ICMR doing, what is NCDC doing. You have put things into perspective, and you have made clear that NCDC is the agency which submits the data to GLASS. And as we know, GLASS is the WHO network for the antimicrobial resistance, and it has enrolled so many countries, and India is also one of the countries. And NCDC is submitting data to the GLASS, and NCDC is getting the data from the ICMR networks. And as you rightly pointed out, that the state has to have their own agencies, because otherwise we cannot, completely have the complete data with only 70 people, actually contributing to this. Which brings me to this question that you very rightly said, actually, that, this is the need of the hour. And now that the government is involved in it, it makes it all the more simple for these states. So would you think that and it's very creditable that you started it just before the pandemic, and the steam did not stop during the pandemic, and it went on during the pandemic beautifully. So that is a big credit to this particular network. Now, I want to ask you that in this scenario, what are the tools that have helped you? Do you think that the newer technologies, the software, the artificial intelligence has helped to better these processes? How have they bettered the portals and the WhoNet, which all these couple of labs are using, which are a part of this network?
Ma'am, could you just repeat? I lost you in between.
Okay, so I was appreciating the fact that you had done such great work, and my question to you was this: that how has the newer technologies, the newer softwares, and artificial intelligence, digitization, how has it helped you to better this process of the surveillance all across the hospitals into the network? Can you hear me, Sonal? Sonal, can you hear me? Am I audible to you? Aruna, can you hear me?
Yes,
Yes,
ma'am, I
okay.
can hear.
Sonal, did you lose me again, or are you able to can you hear me? I think we are facing some technical issue with Dr. Sonal. Sonal, can you hear me? Okay, we'll come back to Dr. Sonal. Maybe there is some
Am I
issue with...
audible?
Yes, you are audible. Can you
Am I
hear us?
audible? Can you hear me?
Yes, we can hear you, but I think you cannot hear us. Is that so? Dr. Methili, can you hear me?
Yeah, I can.
Okay,
Yes.
Sonal, I think the organizers please convey to Dr. Sonal that I think she is audible, but we cannot hear her. So, I mean, she cannot hear us. So maybe I'll shift on to Dr. Methili in this time, and then we can come back to Dr. Sonal. So, Dr. Methili, now taking a step back, because when you do surveillance, you have to have data with you. And how do you have data? Because you are going to input the correct data into your systems. You are going to make the antibiogram. You are going to have correct reporting in the microbiology lab. You are going to, have your systems in place. Only then we'll be putting the right information into the network, and that will help us to have our next steps ready. So how have the recent advances in general, in various other ways in which we can measure the antimicrobial resistance, and particularly in the molecular field, how have they helped in the early detection of the antimicrobial resistance?
So good morning all, and I thank the organizers for having me over here.
Yeah, am I
Good
audible now?
question.
Yes, Sonal,
I
we
think
can hear
Dr.
you.
Sonal is back.
Can you hear us? Can you hear me, Sonal? Dr. Sonal, can you hear us? So any of the organizers can please contact Dr. Sonal and tell her that she probably cannot hear. So we'll continue with Dr. Methili. So please, over to you, ma'am.
Yeah. I think she's having some problems with the
Yeah,
internet, maybe.
yeah.
When we talk of antimicrobial resistance, like you rightly said, and it is the microbiology lab which comes into function over here and which runs on the basic principle of garbage in and garbage out. So here in molecular methods have brought a different dimension to a microbiology lab. The microbiology lab, which was constrained by biochemical methods, is suddenly seeing a totally different
I,
dimension.
I
Uh,
can't hear
the
this.
the automated sensitivity brought a different dimension to get few years back, but now molecular has totally revamped it. So when we are talking of molecular, especially the recent ones, and COVID also taught us that molecular methods can be spread throughout the country. Till that time, we were of the impression that molecular methods are only in very posh labs, very high-end labs, which have very high-end people also with them. But now COVID taught us that molecular methods could go to every nook and corner of the country. So when we are talking of molecular, yeah, because there are some resistance genes which we could identify with the molecular methods. So that is helping us because that gives us the speed of identification, a better treatment module to the clinician over there, and a better treatment to the patient itself. Now, when we talk of molecular, so when we are talking of antimicrobial resistance, we all have to keep in mind that molecular method will detect what we are searching for. So primarily it would be detecting what we are searching for. So if we are searching for a specific gene, yeah, or in a multiplex PCR, it could detect a panel of genes, but nothing beyond that. So we are not saying goodbye to a phenotypic method when we are going to a genotypic method. Like, so it is both together, both complementing each other rather than competing with each other or replacing each other. So it is both complementing together. The best example what we would have in hospitals these days is BioFire, which detects a big panel of genes for resistance and which gives immediate like answers also to us. Or maybe in a patient of pneumonia, if the cause is a viral cause, then it rules out bacteria totally. So the molecular methods could be more useful for ruling out certain things rather than ruling in certain things. Because why I'm saying that, when you're talking of a pneumonia panel, you would have maybe 5 bacteria detected, and these automations also give you the copies per ml. So now 5 bacteria can't be treated. So it is not the, but those which are not detected are at least ruled out. So the ruling out would be more useful over here rather than ruling in. Tuberculosis is one biggest example where molecular methods have change the treatment, because the traditional DST would require many weeks, whereas the gene expert has come up with the XDR cartridge also now. So rifampicin was already being results was already being known to us. Now we have the XDR cartridge also. So within a day there is a report given out, and the clinician has it in his hands that what am I looking at? I mean, what the DST will still continue. We are not replacing the DST, but the report is in hand, and what is he or she looking at, and how does he manage the patient in a better way. But again, in our own country, we have our own problems because molecular methods cannot reach, though RT-PCR did reach everywhere. These are very expensive things, expensive tests. So there has to be a discretion in ordering these tests also. I mean, a patient coming just with sore throat, you cannot be ordering a respiratory panel on BioFire. So there has to be discretion over here on which test would be ordered when, because these are all expensive tests. All patients may not be able to afford these tests. But in critical care settings, when the patient is critical, when the choice is to be made, so instead of giving a high-end dose of meropenem and colistin or ceftazidime avibactam, this would definitely bring a lot of change. We have multiplex PCRs for genes for carbapenem resistance also, which would define whether ceftazidime avibactam can be used or cannot be used, or aztreonam has to be used with it. So it is going totally high end, agreed. We would not advise a molecular method immediately for urine culture. Patient can still wait, but the discretion will have to be used. But it is going a long way in helping with the antimicrobial resistance, because the unnecessary use is going to be like controlled. And of course, the unnecessary use has many disadvantages. We go on to long-term disadvantages, drug resistance, which comes up even to the newest of the antimicrobial, the Clostridium difficile, which can spread in hospitals very easily. So if we can control that by using such methods, it would be very, very helpful. And now many companies are coming up. These are the commonest ones which are being used, but there are many companies coming up with such panels of sepsis screen or pneumonia screen or meningitis screen, which could help us over here. Like,
Thank you.
yeah.
Thank you for that absolutely wonderful answer, Dr. Maithili. And you have brought out two very crucial points. One is that, the whether it is artificial intelligence or whether it is automation, they can never really, really replace the actual interpretation of the microbiologist, but they will help the microbiologist to cut out the unnecessary scut work and make his or her life simpler. And the second point you brought about was very relevant again, that during the COVID, so we are, discussing this, and I would encourage all panelists to talk about the COVID times also, the 2 years that have been there behind us, that during this time, molecular diagnostics received a great boost. And innovation is continuously happening in this field, that how to make it more affordable, how to make it go into the field. We have lateral flow assays which are coming in. We have smarter point of care tests which are coming in. And also at this time, I think it is, I should point out this also, that not only the molecular, we have these innovations happening in flow cytometry. We have innovations happening in whole genome sequence. We have innovations happening in bioinformatics, which is going to bring this particular aspect of antibiotic sensitivity and resistance reporting. It is going to make it faster because time is of the essence. But not to say that we are going to leave the traditional methods. We are going to use the traditional methods where required. Which brings me to my second question, actually, and you've already started that concept, is that the clinician or the microbiologist has to decide which test when, which sample when, and which brings us to the question of diagnostic stewardship. So would you throw some light on diagnostic stewardship and how does it actually help in the AMR? And you very rightly said sometimes it leads to a disadvantage. We are reporting normal flora, and that is where the microbiologist comes in to interpret that.
Yeah.
So would you throw some light on diagnostic stewardship and how it improves the quality of reporting in microbiology?
Yeah, so when we come to diagnostic stewardship, we are like looking at two arms. One is the antimicrobial stewardship, one is the diagnostic stewardship, one is the front office, the hospital, the patient, and one is the back office. Labs are always called back office, though microbiologists are no longer back office now, but it becomes the back office of it. So they are basically coordinated interventions, ideally done to have the right diagnostics at the right time, to have the right microbiology diagnostics at the right time to the right patient. And it starts right from sample collection to giving out of report. So it starts at the right choice of patient for the right sample. So a very simple example is a catheter urine specimen which is drawn. So if the staff is not trained for how to draw a catheterized urine specimen for culture, we are going to have it because we end up giving maybe anything then. A multi-drug resistant or pan-drug resistant Providencia Redgeri would be the commonest in a catheter
Yes.
then. So
Yes.
that is the thing, that how to draw the specimen. So diagnostic stewardship would mean the lab teaching the hospital how to draw the specimen, intervention in time, and surveilling, like doing surveillance of the teaching methods also, whether they have been trained, they are drawing the specimens well, are the specimens transported well to the lab in proper conditions, and when the sample is received in the lab, is the sample being processed in time with a proper method also. I mean, you can't load a urine into a bacterial alert. So, I mean, the proper method is also very, very useful. Whether the interim report is being informed to the consultant. Like you see something in gram stain, the hospital has to be informed, at least for some critical samples. So, is the interim report being informed to the hospital? Are the culture reports being informed in time? Many a times in a hospital lab, you would just authorize a report. Maybe the resident would see it in the hospital, but the consultant or the relevant person might not be told. And the report is just authorized in the software, kept in the software. And 2 days afterwards, somebody would just say, oh, was it Brucella? We never saw it. So this would start happening if the microbiology lab does not talk to the clinicians. Still, the clinicians are not very great in seeing the system in time. So it is like continuous communication. It may be through phone, it may be through software, it may be through WhatsApp, any mode. But it is like go to them, bang on them, tell them, let them get irritated because of some more things what you're telling. And this all would form a very ideal diagnostic stewardship over here, because when the good report goes, that is when the antimicrobial stewardship would start. Because the cultures are very, very important to form a database too, because for empirical treatment we have to have some data in hand, like what empirical treatment to start. And of course, after the report comes, the clinicians are tuned to shifting over, escalating or de-escalating the antibiotic, or changing over totally, like. So that would mean a total process, right, from sample collection. And maybe I would encourage microbiology labs to stay open at least for 12 hours. 24 hours also is very, very ideal, but at least 12 hours, because there are some places where a microbiologist would visit for 3 hours, 4 hours, 2 hours, or 1 hour also. Like, we can't be talking only about the high-end hospitals where we know that things are in place, but there are many, many places where they are not. So diagnostic stewardship would not come up properly if the lab is not active. So the lab has to be active. The lab people to be active, the microbiologist has to be active, and very active in fact, because
Very true.
slight
Very true.
activity will not help it over here. So this is how we would lead to a total ideal report going in, and helping the clinician to a proper treatment option to the patient, because stewardship would mean giving proper treatment, the right treatment to the right patient at the right time.
Correct.
So
Very
it should
rightly
culminate in
said.
that. Yeah.
How diagnostic stewardship is going to help into antimicrobial stewardship.
Yeah.
And I'm happy to say that, microbiology has actually become center stage.
Yes.
Many years back when I took microbiology, we probably thought that it's a kind of a back-end function, though
Right.
I'm sure all of us were very, very passionate about the subject and still am. So I think, but now we are all here for a long, long time to stay. In fact, our role is evolving. We have to come to center stage. We have to become clinical microbiologists, partners in the treatment of the patients. And you very rightly said that diagnostic stewardship is something which we have to teach each and every person, each and every technical staff, each and every doctor, each and every nurse who is collecting samples in the hospitals. And like that, we will form a good ecosystem which is going to help the antimicrobial stewardship. So, Dr. Maithili, do you see a lot of interdisciplinary collaboration between departments to promote antimicrobial stewardship?
Yeah, because luckily few years back the infectious diseases consultants started coming in. So initially they were in big cities maybe, but like if I'm talking about Pune, since last few years we have had many, and they are a boon in a way, because till that time we had only heard about them. But when they came in, so it was microbiology and ID collaborating with each other. Then it started off, see, when the trust increases, then the interaction increases. Till the clinicians don't trust you, they are not going to interact with you.
Yes,
And for
yes.
that, somebody has to take the first step. So maybe where, see, there's no question of ego. I mean, microbiology was a laid back subject. So it is we who have to take the first step now. So we take a first step, then we have a, a person in front taking his step also and asking us. Then you could have the surgical, pre-surgical prophylaxis in place, because you could convince them that no, you don't need to give vancomycin over here. I mean, a plain and simple cephalosporin is going to do well over here. So for this, a trust level has to come up to an extent where the clinicians do not start any antimicrobial without having your report in hand or without talking to you. So here the interdisciplinary approach would come up. So the surgeons are needed, the medicine guys are needed, the ID physicians are needed. Every now these days even obstetricians, because phosphomycin has come up. So phosphomycin is given everywhere, like, so each one is needed. And like we get different calls, like somebody, a clinician would ask that why aren't we reporting vancomycin for a E. coli. So you have to just tell, you have to just talk to them and make them understand, and how intrinsic resistances work, how acquired resistance works, and how some things just can't go with some things, like, so this
Absolutely.
interdisciplinary approach is very important.
And
Yeah.
I think long gone are the days when microbiology used to be, a laid back subject, just like as you
Yeah,
put it. And
agreed.
now I think the people, the youngsters who are listening to this,
Yeah.
please be prepared for a very, very enriching and a very, challenging field of microbiology, where
Agreed.
you are not to expect only day duties. And that also, sometimes we feel that it's not even 9 to 5, where you were talking about 3 hours or 4 hours.
Yeah.
Microbiology is not that. Microbiology is actually now 24 hours, and we must encourage our residents and youngsters to think of it as a very important supportive discipline. And I would not even say supportive, I would say an equal partner in the treatment. So you very rightly said that. Now, in this scenario, do you think that point of care antibiotic testing, antibiotic sensitivity and resistance testing machines have any role? If so, where? And what are the pitfalls which are associated? Because I know some clinicians, would say that I would like to have such and such in my clinic, and immediately I'll be able to tell the result to the patient. So, what are your thoughts on this?
See, again, it's a delicate balance between everything. I mean, you have something which will always come with pros and cons. It will give you a fast result. The validation of the equipments would be very, very important. So it would be mostly genotypic results. So everyone who is interpreting the results has to be aware of what that target positive would mean, like. So if
Yeah.
it is a CTXM positive, genotypically, what is coming phenotypically? Is it coming cefepime sensitive or resistant? All these things have to be done. point of care equipment, like I spoke earlier, also have definitely revolutionized our treatment aspect, but they still have. I mean, we are not saying goodbye to phenotypic methods. We are going to do cultures. We are going to do sensitivities. And certain point of care equipment, like a gene expert kept in a clinic of chest physician, may help because immediately would be. But then again, there is a pre-processing to be done to the samples. If that is not done well, the results are going to go haywire. Like COVID brought point of care testing, especially with Abbott and Thermo Fisher coming up and the airports being lined up with those equipment. So there is definitely a place for point of care, but it has to be taken with caution. We have to have right people
Absolutely.
interpreting them. Like so, it
Absolutely.
won't
And I think,
replace that.
yeah. And I think that clinicians should also realize that, the microbiology support is required. And I would
Oh, yeah.
go on to say that near point equipments are better off than actually point of care,
Yeah.
especially in, in automated sensitivity results. So thank you very much for those answers.
Yeah.
Sonal, can you hear me, please?
Thank you.
So if if you can hear me, we would like to continue with you. So I was actually appreciating the fact that, you have done such a great job even during the pandemic. And I wanted to ask you that in this era of digitization, artificial intelligence, and newer technologies coming in, just like Dr. Mehri was also pointing out, how has this helped the network? How artificial intelligence, how has this helped to better your portals? And how has it generally helped you to have a control over this network? Over to you, Sonal.
Okay, thank you, ma'am. Am I audible now?
Yes, please.
Yeah. Ma'am, actually, in our network, we have used the WhoNet software for collection and collation and analysis of data because it is something which you can customize. It's like creating a peg hole with spaces which can be filled in by each lab, and it's a very user-friendly software and can be what you don't even need an internet connection. You just need the software and a computer, and we found it very, very useful for collecting the data. But later on, when we were analyzing the data, it became very difficult for us because in our network, like we have 24 labs, and these labs submit the data on a monthly basis. And initially, a lot of handholding was required for this. So at that time, I used to really wonder that one should have an artificial intelligence algorithm, and something which could, like one of my juniors once said, that you want your brain to be put into the machine, ma'am. That's not possible. So something which is, which would immediately point out that these are the outliers and these are the things, which even for as a laboratory in charge, all of us would love some kind of logarithms in that manner. Recently, one Excel tool has been created which allows us to filter a lot of information from the Excels that we generate from WhoNet for each lab. And that immediately tells you that, okay, these many fields were not filled in. These are the fields which still need, the panel is not complete for these organisms. So definitely AI is going to go a long way. And like Dr. Mathili was talking about the POCs, now it's become every clinician's fancy this thing that now we are on the other spectrum. Earlier they felt they don't need microbiology. Now they feel they need the microbiology standing with them in the clinic performing their POC. So now it's turned absolutely the other way around. And with all the COVID antigen tests and Abbott IDs and things like that, they now want the antimicrobial susceptibility results also in few minutes. So I think we are in for trouble in the coming few years unless something
Absolutely.
comes up from the industry. So
Absolutely.
that's one.
Sonal, you hit the nail on the head. Please go on.
So
Please go on.
I think when we look at the future, this is one thing that we have to look into this domain. That if suppose a patient in the ICU and we could give a report of AST, nanoparticles, or AI or whatever, that would be the dream for every microbiologist.
And here
So
you see the development of a new discipline, perhaps, which is in between microbiology and the clinician, because again, as you rightly said, there is a need for this now because everyone wants everything very fast. So if you are sitting in your clinic and you get to know that you want to, if maybe you're going to treat a urinary tract infection and you get to know that this is going to be resistant to such and such and you want to give such and such, I think it is a boon. Also in the critical care, like you pointed out. But on the other side, I do know that all these newer point of care testing, even in the airports, it was playing havoc, because they were giving the CT values of the COVID, very higher CT values also they were giving as positive, and there was an unnecessary detention of people at the airport. So that's the flip side of it. But you are a great leader, Sonal, and you have been leading your team very, very well. What is the role of leadership, do you think, and accountability in antimicrobial stewardship? Because without a proper leader, we cannot sustain these programs. You can start them, but we cannot sustain them. So could you throw some light on this, please?
Right, even in WinSAR-D, ma'am, as very rightly said by you, it all depends on the leader. Even in WinSAR-D, we ultimately had to find a channel where we can get some government support to the network. Because unless and until those leaders, those bureaucrats at the top are convinced, that yes, this is some good work and this has to be taken forward, there is no continuation of that. Because after a while, and I feel that after a while, it has to be the vision of somebody at the top to take it forward. And I've had my set of challenges, all the meetings and all, we've discussed these challenges. One of the major issues that, because there is no top-down approach, what happens is that there is a lot of issues like procurement, like erratic supplies, like substandard media, substandard antibiotic discs. And in the government channel, that is extremely important, because now there are two clauses. One is the government e-market gem clause, and the other is a
Yes.
Make in India clause. Now, Make in India clause does not allow us to buy anything from Oxoid and BD or any other country which doesn't manufacture their antibiotic disc in India itself.
Country.
Now, I am not saying anything which is made in India is not good or anything which is made outside is good, but our own experience in the laboratories have come up with few discs we face problem. Majority, 90% of the discs work very fine, but 10% of the time we get stuck somewhere. And when there are these procurement and erratic supply issues, then it becomes very difficult for government laboratories, especially the smaller laboratories, depending on how they circumvent these issues. The other issue that has always come up is that there is not an availability of the automated systems or the standardized guidelines. There is a manpower issue in these laboratories, and all these could be very easily taken care of if somebody at the top would think that AST is an important aspect of every lab, especially a government microbiological lab, even if it is a 50 or 100 bedded hospital. Many a times people have refused to be a part of our network because they felt that these are issues which will not be taken care of by somebody at top. So they felt
Absolutely.
little lost. They were single microbiologist lab with two technicians, so they wanted to be part of the network, they wanted to share their data, but their hands got tied with this. The other thing that we realized in our network were related mainly to individual issues which were sorted out very beautifully by all the microbiologists. I congratulate each and every one of us, with the COVID, without the COVID. All of us worked really very hard on the bench. So I don't take the credit for running the network, like ma'am said. I give the credit to all 24 labs for making it practical and for making it the data usable.
Yeah.
Thank you,
No,
ma'am.
I think you really, and I think that's why we realized that in the global action plan, when it was translated into the national action plan in India, the sixth goal was effective leadership. That was
Lit.
added on for India. And I think India, like many other low and middle income countries, it requires a very effective leadership. You actually hit the nail on the head, that because though we've come a long way, I think the government has realized, right from the time the NDM was discovered, it put a spotlight. Earlier, when I used to go for conferences internationally, I would feel very small because, I would be in the audience or maybe, delivering a lecture, and I really wouldn't have any data from our country because there were no networks. So the data which was coming out was from papers or, some erratic here and there somewhere. And they were these foreigners who were talking about Indian data. And that was the time I used to really feel small. So we have come a long way. The government has focused a lot on this, but there is a long road ahead. And unless and until we have, maybe a team or maybe, a single person in charge of antimicrobial stewardship, like you said, I think we will benefit a lot from that. So thank you, Sonal, for those
Ma'am,
wonderful insights. Yes,
I can,
please. You wanted to
if I
say.
can add here a little thing. Like you said, the government has come a long way. Actually, the government, I believe, sees what we show them as technical people.
Yes, yes,
You know,
yes,
the government is like that lady in the court who's able to see what is shown to her.
yes.
So unless and until we put our data in front of them and we show them, like very recently I met the principal secretary of health Delhi, and I showed her the work from Vinsadi, and she told me that as a single 100 person, if you could handle this much, then definitely we need to work on pan in Delhi ground and bring all of them on table. And I now have a letter from her saying that MAMC is going to coordinate all the state medical colleges data, and very soon we'll be enrolling all the colleges in the network to share that data. And very soon, with the support of the administrative authorities and the leadership, we'll be taking it forward to many other things. And I think it can be replicated in every state,
Wonderful,
because not
wonderful.
only the government of India but the state governments have also geared up to a large extent to this problem.
And that's how, again, we come to the same question that we as microbiologists, as clinical microbiologists, as leaders like yourself of networks, we have to bring it to the fore. We have to sort of give the data, and the data has to be cleaned up data, and it has to be effective data so as to, convince the administrators to be able to do something. And I feel very happy. It's my alma mater and MAMC, and I feel so happy that under your leadership in microbiology, it is going to achieve great heights. Now, we've talked about the problem a lot, and we've talked about how correctly we can present this information. And now we know the problem, that there is a lot of antimicrobial resistance. So now we have to talk a little bit about the solution, which brings us to the antimicrobial stewardship programs, which have been carrying on in hospitals in major metropolitan cities. And because of the accreditation, it has become almost mandatory to have an antimicrobial stewardship committee and a program. So I'd like to bring in Dr. Aruna Pujari here, who's also a very renowned and a very committed microbiologist. I know her personally, and it's a great pleasure to have you here, Aruna. So how have these antimicrobial stewardship programs performed in hospitals in generally, and what do you see as the challenges? And also, do you see that, you feel that these programs can be sort of translated into smaller hospitals, into standalone clinics, into communities? What is your take on that?
Thank you, ma'am, for your kind words. And at the outset, I'd like to thank Elets team for giving me an opportunity to be here. And I think, yes, over the last decade, most tertiary care institutions have adopted an antimicrobial stewardship program. And thanks to what you pointed out, the accreditation bodies, for example, NABH, it's compulsory for an institution to have an AMSP program, have an AMSP committee which is active, dynamic, and working towards improvising solutions to AMR. So if you go to tertiary care centers, most of us have an AMS program which is running at the meaning at the forefront in some way or the other, trying to preserve whatever antimicrobial agents that are there. There are metric measures also that we use to understand whether that program is running successfully, whether we can make any changes and other things. But India having a heterogeneous healthcare system, I think we have plenty of challenges. Amongst the most important being that there are too many fields or specialities actually prescribing antimicrobial agents. We probably learn about antimicrobial agents only in second MBBS at the pharmacy level, and then while reading pharmacology or studying pharmacology. Subsequent to that, we seem to have absolutely no refresher training program. So I think that's something we can of course allow many specialties to prescribe antibiotics, but I think there is need for some kind of a refresher training program on both infectious diseases as well as pharmacology at different stages in different specialities based upon whatever organisms get encountered or infections get encountered there. Uh, Very importantly, there is need for strengthening laboratories and particularly microbiology laboratories, because most tertiary care institutions are associated with labs, good microbiology labs. But if you go to see today, the need is that we need to have microbiology labs percolating down to primary care centers. There has to be some mechanisms, and we've already discussed about some point of care or near point of care devices and tests. I think all of these would help in doing that. The need is to recognize that microbiology is important, infections are important. In fact, there was a grams report published only recently in Jan 22 in Lancet, and which talked about meaning it's probably the largest comprehensive data on drug resistant bugs globally, and they said that almost 4.95 million people died in 2019 because of antimicrobial resistance. So it's huge. It's much more than what we ever thought it was, and the problem is much bigger in low and middle income countries like ours, where we need to recognize infectious diseases and bring in solutions, because we really don't have any other antimicrobial agents. We've also been talking about surveillance. As Sonal ma'am pointed out, probably there are few labs which are into these surveillance networks. We need to get in more labs. Whichever lab is reporting on microbiology needs to be part of this surveillance network, because it will give them an opportunity to improvise the quality. You would agree with me that quality reporting is one of the cornerstones of supporting your AMS program. So the moment you are in a network, naturally, along with all the team members, you'll be forced to do quality reporting, and that's again an important challenge that we face today and needs to be kind of looked at. And I think we need to go a long way into AMS. It's very good that we have some national documents on hospital infection control programs. We have a national document on treatment guidelines, standard treatment guidelines for common infections. These are excellent documents, and these would help us even take our AMSP programs to the community, which again is another need. So those are the different challenges, and probably even to some extent solutions to having a better AMS program for us here in India.
So you brought together everything, Aruna, and just like Dr. Sonal had said, every laboratory contributing to a network, and I think these are the state laboratories which have to now do. So there has to be a sort of a, tributary system. All the little lakes and tributaries have to feed into main ones, and I'm sure that with the governmental insight and the governmental focus, which is to be again got by the microbiologists only. So I think we have a responsibility now towards this whole thing, and we cannot shirk it away. I sometimes feel that it is easy to talk about it, like we all are, and it is very difficult to do on the ground. So we have, sometimes I feel that in hospitals we have the documents. Sometimes I go to survey for JCI and I realize that we have the documents, we have the teams, but still nothing is happening on the ground. So there is a gap between the theory and the implementation. And that will require a multidisciplinary approach, and that will require a lot of training. That will require some sort of clinical decision support systems interwoven to help the clinicians, because I do agree that they are also at the forefront, and they are, stressed out, and they have 1,000 things on their mind. So they need some help in this regard of antimicrobial. So maybe we have clinical decision support systems coming in. And what you pointed out about strengthening the laboratories is the basis, is actually the pivot. And again, that will only come when we are sort of linking up every laboratory in the country. So very well brought out points. And now I come to the sister of the antimicrobial stewardship, which is the infection prevention and control. So on the one hand, we are trying to prevent the emergence of antibiotic resistance. And on the other hand, we are preventing the spread. And the spread of multi-drug resistant bugs, as you know, is going to take place through our hands, to the hands of the healthcare workers, nurses, environment, etc. So what do you think, how important is this IPC in this regard? And what are some of the innovations that may help prevent the spread of antimicrobial resistance?
So as you rightly pointed out, meaning no AMSP program can run without an IPC program. Meaning they absolutely have to go hand in hand, and both of these are interdisciplinary efforts, and they are very well woven into each other. They cannot be handled alone. It has to be a team effort. When it comes to infection prevention, as you correctly said, it is basically trying to prevent the spread of organisms, controlling outbreaks, and this is an absolutely essential part. Once again, thanks to all the accreditation programs that we have in the country, even IPC is an essential program for any accreditation. So that has definitely brought in focus towards both AMSP as well as infection prevention and control. And some very basic measures. Actually, we need to start from some very basic measures, ensuring that people understand that hand hygiene is important and one of the key features of preventing infection. So strengthening hand hygiene at every level. And we all know that as healthcare workers, there are so many layers of healthcare workers who work within the healthcare setting and will come across patients and will be, getting an opportunity to do hand hygiene. So hand hygiene is something very important. Environmental cleaning. We are talking about multi-drug resistant pathogens, which are currently problems to us, and because we don't have new antimicrobial agents in hand. So spreading of these multi-drug resistant bugs, as we say, an important part of it is good environmental cleaning and disinfection. So there again, I think there is need to strengthen, and we know who does environmental cleaning and disinfection. These are people who probably have no basic training, and we in hospitals actually train them at a frequent interval in their own language. So these are some of the very important aspects of IPC that need to be going hand in hand and working with an AMSP program. As regards innovation, I think COVID pandemic also has brought in a lot of gaps in front of us. So the ICU or the COVID ICU was actually a place where naturally not too many people visited, and everything was under barrier precautions and strict use of PPE. Now in these areas to do audits also was difficult. So meaning having the support of software programs, training people in-house in that unit to undertake audits was an important thing. So I think IT is going to be the next big support that microbiology and infection prevention or AMSP requires. And they really need to pull up their socks to support us if we were to, take larger steps ahead. The second thing could be, in terms of environmental disinfection, we know that monitoring environmental disinfection is something which is very, very important, and the traditional methods of simply observing how it is done is not really going to help. So there are some newer methods like ATPase detection. Of course, they have their drawbacks, and they're going to be a little expensive, but nonetheless, I think in areas where these MDROs, or if there is an outbreak and such things where environmental cleaning disinfection becomes very important, this is also going to be an important step forward or an innovation forward. There are also touchless disinfection systems. For example, the UVC robots. Now, these are evolving in a country like India. Naturally, cost is going to be an important aspect, but we must also understand that meaning cleaning requires to be done prior to any kind of such touchless disinfection. So the basic concepts of IPC need to be preserved. You may have any number of innovations that are coming in, but the basic concepts need to be preserved, and we need to go ahead. As Dr. Maithili mentioned, we are never going to go away from culture so easily. Nonetheless, the rapid diagnostics would support us. So similarly, here again, innovations are coming in. IT plays a very important role, is what I think.
Thank you, Aruna, for bringing out such important aspects and for your wonderful insights. Now we'll go on to the other aspect of the solution, and that is the One Health approach and research. And thank you, Dr. Shahzad. You've been very patiently listening to all this, and I'd like to bring you in now. So could you throw some light on the use of antimicrobials outside of the hospital, that means in the environment, in agriculture, poultry, and how it overall contributes to the development of antimicrobial resistance?
Yeah. Good afternoon, everyone. Thank you, ma'am. And thank you, the organizers, for having me as a panelist for this particular discussions. Yes, ma'am. So the question is actually like till now we have spoken about antibiotics being used in healthcare sectors dealing with patients or human beings maybe. But the antibiotics are not limited to the treatment of human beings, and the majority of the parts, to some extent, we know, but is being used for various other purposes in fields like agriculture, livestock, poultry, fisheries, and animal husbandry also in case.
Yes.
So I would just take you. I'll give you a brief about the historical perspective also, how we basically landed in such a condition. So antibiotic, as we know, is most commonly used to cure diseases in human beings. But apart from that, it is also being used in curing diseases for in the plants also, crops as well as livestock and animal husbandry also. These are very commonly being used as growth promoting agents and preventing and curing infections. Also, there are different classes of antibiotics which are now being or was being already used in agriculture industries, like macrolides were there, penicillins, tetracyclines, which are the major ones. There have been very good reports from various authors. Like in 2015, we had a very good report by Van Berkel, which said that in animal husbandry itself, the average yearly consumption of antibiotics estimated around 172 milligram per kg in pigs, 148 milligram per kg in chicken, and 45 milligram per kg in cattle. Now, these are like not ordinary amount of antibiotics on a yearly, though it is on a yearly basis estimated reports, but these are quite huge amount of antibiotics found out by this particular report, and this was just one report. Also, if we look at the historical perspective, streptomycin and amikacin has been usually used widely in plant agriculture, which gradually resulted in emergence of resistant strains of Pseudomonas and Xanthomonas. Gradually, the tetracyclines also were used in swine and the poultry industry, which resulted in gram-negative resistant organisms like Pseudomonas again and Enterococcus. Also, we got Shigella dysentery, which was showing resistant to tetracycline in the 1950s itself. So the point is, like, many organisms have been showing resistance because of the use not only in human practices, treatment of ours, but also in agricultures and the poultry industry. Now, having said that, similar various other these studies have been done wherein not only the antibiotics used in poultry and agriculture, but also the effects of spraying and the products or the air contaminations occurring or because of these antibiotics carry
Yes.
many of the products of these particular antibiotics being used there in the livestock still itself, resulted in drug resistant organisms, like maybe Enterococcus was the most common one studied, which basically was seen. So there are good studies for this also, like vancomycin resistant Enterococcus was found in Turkey, the food itself, and the farmers who were working, also the nearby community people also. So it spread through those particular areas. Similarly, in broiler chickens and the broiler chicken farming industry, the whole farmers and the nearby areas, so they were affected by vancomycin resistant Enterococcus and strains of tetracyclines, where the pigs were feeded with chlortetracyclines for better production. So these are evidences, and the literature basically supports as an evidence that antibiotic used in food animal industries gradually results in antibiotic resistant bacteria in humans subsequently. So we are basically overusing or maybe mistreating the patients in some regards, but the like it is not the sole reason for that, and solutions for this particular things should be taken care of also, and this is what care for one health basically points out. So and the reasons are many, like direct, indirect effects of antibiotic use in food and animal industry. Because of exposure to the farm animals treated with antibiotic, consumption of food contaminated with these particular resistant bacteria can cause outbreaks, which can result in drug-resistant diarrheal diseases. Consumption of various antibiotic meat products can also induce resistance in normal flora of the human body in the GI tract. So it can disturb the microbiota of the gut also, which basically can result in drug-resistant bacteria shed through feces and contaminate water and soil and those resources, and then get circulated in the environment. Some of the
Thank you.
other indirect factors are also there, like dispersion of these particular microbes through fertilizers. And so it is critical that we recognize antimicrobial usage in agriculture and food industry, which can lead to resistant bacteria. And some policies do exist, but it has to be re-explored and revised to limit this.
Thank you, Dr. Shahzad. I must compliment you that you have taken up such a difficult topic, which actually requires I don't know, a 5-day conference, because the use of antibiotics outside of the hospital is a major problem. And, surprisingly, in India, which is not that much a meat-eating population, but I remember Dr. Herman Guzens, who is he started the global point prevalence survey in Holland. He had actually said that it is in Amsterdam, perhaps, more of the antibiotics are being used in the animals rather than in the hospitals. So, but this is a problem which is waiting to explode. And it is high time that some certain rules and regulations are set into this spectrum. Otherwise, we will be facing a huge problem again. So thank you for that wonderful answer. Another aspect which I would like to touch upon with you is that what is the use of vaccines in overall preventing antimicrobial resistance, whether for the humans or for the animals, just like you were talking about?
Yes, ma'am. So vaccines have an unprecedented impact on the health community, and it can be used for decades with a much lower maybe probability of resistance emergence compared to the antibiotics. And it is proven time and again that antibiotics usually doesn't show a resistance pattern. It can be because of uh, the organism itself changing itself, like antigenic drift or antigenic shift, but otherwise vaccines are quite stable. And new technologies and approaches such as reverse vaccinology, novel conjugants, then structured vaccinology, and bioconjugates. So these are the various fields where which has to be tapped in terms of resistant bacteria when we talk about. And it can be also because if we can always explore the possibilities of designing the bacterial outer membrane, because there are certain vaccines which are being explored now, which works on the bacterial outer membrane vesicles. Those are OMVs, and together with the progression in polysaccharide conjugation and antigen designing, we have a promising future in terms of various vaccines coming through in various clinical trials, phase 1, phase 2, phase 3, like that. Now, what we need to address here is when we talk about antimicrobial resistance and vaccines, there has to be new and sustainable investments in antibiotic resistant vaccines which have to be developed, and alternative interventions in terms of vaccines which are already existing. So, as we all know that vaccines are used prophylactically. So, what happens is if we use them, this will be effective before the bacteria even start multiplying and
Yes.
following the initial infection itself.
Yes.
So we basically limit that infection to spread only. So that is how it goes in terms of limiting the infection, and substantially reducing the likelihood that the resistant conferring mutations will emerge only and spread. In addition, where antibiotics have a single target, such as the bacterial cell wall maybe, or translational machinery, vaccines usually contain multiple immunogenic epitopes. Thus, more mutations are necessary, like to confer resistance to. So this is the good side of the vaccines. Furthermore, vaccines indirectly affect antimicrobial resistance by preventing the viral infections also, as we saw in COVID-19 also. So, for example, influence of the vaccine can reduce inappropriate use of antibiotics and secondary bacterial infections and super infections also. Like in case of any influenza virus, it can occur. So various studies have also indicated that there is an antibiotic prescription reduction up to 13 to 60% wherein vaccines were used, and it resulted in lesser secondary bacterial infections. And time and again we have seen that if good vaccines are available, like we had for smallpox, and in case of poliomyelitis and other incidents like diphtheria, tetanus, pertussis, so we have had bacterial vaccines also available with us. Now is the time that we start investing and dedicating more things towards. And there are actually good vaccines in clinical trial phases 1 and 2 and 3 for various infections like Clostridium difficile, Salmonella, Shigella, wherein the jump from the third phase of trial or the fourth phase of trial is needed. So maybe we can invest, the government agencies can come in, play an important role in this particular type of interventions.
Wonderful. I think, we could go on talking about your wonderful insights into this, but that we just have a, little restriction of time. But before you go, I would like you to also answer this question, because you threw up a lot of research ideas when you were talking about vaccines. You were throwing up a lot of research ideas for our youngsters who are actually listening in today. And what would you feel are the key areas of research, and how important it is for the academia and the industry to get together to even formulate better antibiotics, even formulate non-antimicrobial solutions towards, infections, let's say like phages, etc. And what are the funding agencies that we have these days to support all these research activities?
Yes. Ma'am, again, as we have discussed throughout this session, the main key areas of research would be to optimize use of antimicrobial in animals and humans as a whole. So it has to be optimized first thing. Second thing would be to develop new drugs, which is quite difficult in terms of antibiotics, vaccines, and then diagnostics. Like ma'am also said that it is very crucial that we diagnose the correct etiology first. So we have to have some sort of research planned in that particular manner, and then increase public engagement in AMR. I may be slightly off topic here, but we don't have an ambassador for AMR in India. We had poliomyelitis, various. We took help
No,
from
you are absolutely
celebrities
right.
also.
You're absolutely right.
So
Yeah.
why
Yes.
can't we have that for AMR? Like 15 celebrities coming in together for promoting AMR or just projecting the importance of that. It's sort of a pandemic already. So we have
It's a
to,
silent
like,
pandemic, yes.
it's a multifaceted system now. Then reduce of infection in human and animals, various IPC implementation practices that has to come in, and it has since 2017 after the government took the initiative. Like it's been made mandatory. Now the AMR policy with the NMC is also coming up. We already have NABL, and then we have NABH also. What we feel is that if we basically combine these all together, then I think we just have data from few of the institutes only. So the research part would be to amalgamate the data from NMC and NNBL and NABH, and then maybe we have a small pilot sort of thing wherein we can understand what is the difficulty maybe. And financial investments in regards to AMR related activities have to be, like, it has to drastically increase to maybe 100 folds. And then strong governance, like we have discussed. Second most
Very true.
important thing what I feel is there has to be research in terms of AMR surveillance data, like ma'am said. That dissemination has to be there. It can't be limited to to a particular state or particular like country itself. And then evaluation of the policies. Again, we'll have to go back and AMSP practices in hospitals, and evaluation of the policies where whether we are following the correct policies.
So
And
you
then
have summed it
social.
up very nicely, Dr. Shahzad. You've really summed it up very nicely. And I think ICMR, DST, DBT, and a couple of other international agencies are also there to fund projects. So this is an encouragement to all the people who are listening in today to write projects in these various aspects. And, I'll just like to end with something, because AMR is a multifactorial problem. And therefore, the solution has to be multifaceted. And that is why we have been discussing so many aspects of the solution of the antimicrobial resistance. So I think we are a little bit running out of time, and I'd like to keep in the time. So I extend a very, very big thank you to all my panelists who are really experts in their own field, and they have thrown some wonderful insights onto this topic. Also, for the audience, any questions which you have, you can send through the organizers, and any of us will be happy to answer them. So with this, I hand it over to Kanchi Chawla again to sum up the session. And thank you very, very much for joining in.
Thank you so much, all the panelists, and special thanks to Dr. Namita Jaggi for moderating the session so nicely. Thank you so much. Also, we would like to inform our esteemed gathering about our upcoming events, which are the 4th Farmer Leadership Summit on the 26th and 27th of April, the 3rd Radiology and Imaging Summit on the 26th and 27th of May, and Medical Education Summit on 23rd and 24th of June. We look forward for your constant support in future. I once again extend my warm gratitude to all our esteemed panelists for their time and presence. And please accept a small token of gratitude from our end through these certificates that we present to Dr. Namita Jaggi for moderating the session so beautifully. Thank you so much, ma'am.
Thank you.
Dr. Sonal Saxena, thank you, ma'am, for your views. Dr. Mathili Kavathekar for her insightful views on the discussion. Thank you so much, ma'am.
Thank you.
Dr. Aruna Pujari, thank you, ma'am, for sharing your points.
Thank you.
And Dr. Shehzad Mirza for his keen points. Thank you so much, sir. It was wonderful listening all of you. Thank you.
Thank you, Dr. Namita. Thank you, everyone.
Thank you, everybody. Thank you, and bye-bye.
Bye-bye. Thank you.